All right. Good morning, everyone. Welcome to TeleShadowing. We're live on YouTube. Please feel free to ask questions in the chat box as we go along, and they will be addressed. I'm honored to introduce our mentor for today, Dr. Ahmad. Dr. Ahmad is a graduate of King Edward Medical University in Lahore, Pakistan. Currently, Dr. Ahmad is working as a senior specialist at Corniche Hospital, Abu Dhabi, which is the leading maternity hospital of the country. Dr. Ahmed is currently pursuing a diploma in professionalism and healthcare ethics and is affiliated with teaching for MRCOG Part 3 candidates via a UK-based online group. And now it is my honor to request Dr. Ahmed to begin today's session. Thank you.
Thank you very much, Amna, for such a nice introduction. Good morning, good afternoon, everybody, whoever is joining from different parts of the world. So today's session is hypertensive disorders in pregnancy, and I will try my best to simplify it as much as I can. But before I start talking about this topic, which is a little bit dry, a little bit overwhelming, even for obstetricians. So let me just introduce myself. So my name is Omara. Just a second, I think it just got stuck somewhere. 1 second. All right. So I have done my MBBS from Pakistan. I have post-graduation degrees from Pakistan as well. And second post-graduation is MRCOG, which is from the Royal College of Obstetricians and Gynecologists, UK. I'm currently working in Abu Dhabi, which is the capital of United Arab Emirates. I have recently achieved a consultant license, but currently I'm working as a senior specialist. And I have actually gotten the opportunity to be selected as one of the first specialty trainees, which is a program by Royal College of Obstetricians and Gynecologists as overseas. And it is the first time it has been launched outside UK, and my hospital has been accredited for this program. And I have been given the opportunity. I'm one of the 2 doctors who have been selected. So the point of mentioning this selection is just to motivate you. I'm sure you are all at different stages in your careers, and all of you will be younger than me, much, much younger than me, maybe definitely my children's age. So just want to highlight that whatever opportunity comes your way, just take it. Just don't bother about the time. Age does not matter. And you just have to be persistent and motivated to take whatever comes your way, right? So after this motivational speech, let's get back to business. Now, what are the learning objectives? Why are we talking about hypertension in pregnancy? So by the end of this session, I believe I will be able to, refresh the background knowledge. Majority of you who have done their medicine, who are doing their internships or their residency trainings, they must be very, very familiar with the blood pressure and hypertensive disorders, but let's just refresh it. The second thing is to understand different types of hypertensive disorders in pregnancy. So for non-pregnant population, hypertension is just simply hypertension. This is one entity. But for the pregnant ladies, it's a wide array. It's kind of a full spectrum that ranges from the minimum to the most extreme levels where it can be life-threatening. So as obstetricians or even as medical students, it is very important to understand what are the different types of disorders which can occur in a pregnant lady. Towards the end of this session, I will have an overview of management of hypertensive disorders. I promise I won't take very long. I have tried my best to keep this session as simple as I can. So I'll make sure you guys don't sleep during this session. Now, the basics. What is blood pressure? For a layman, it's just the pressure of blood into the blood vessels. And if you go to the literal meaning of that, that's actually correct, right? So the definition wise or biologically, how do we define blood pressure? It is basically something which is directly proportional to the systemic vascular resistance and cardiac output. Now, what is cardiac output? It is the quantity of blood or the blood volume which is pumped by the heart in a given period of time. And most of the time, it's per minute, which we take and calculate it. So blood pressure, whatever, when you go to see a doctor or when you yourself are taking or measuring blood pressure for a patient, there are always two numbers. There is a top number and there is a denominator. So that is how we check and measure the blood pressure. The top one is called the systolic blood pressure. It is the pressure in the arteries when the heart contracts. That is during the systolic phase of the cardiac cycle. That is why this is called systolic blood pressure. And the denominator or the lower number is diastolic blood pressure. That is the pressure when we measure it when the heart is relaxed during the cardiac cycle or during the diastole of a cardiac cycle. So these are the two numbers, and the normal blood pressure is generally speaking, is 120 over 80 millimeters of mercury. So millimeters of mercury is the unit which is used to describe or write the blood pressure. How to measure it? So if you know that for measuring the blood pressure, a person has to be sitting quietly and should be relaxed, because if a person comes running or just talking loudly, shouting, laughing, the blood pressure is usually at a higher level. This is because of the adrenaline surge in the arteries and the heart pumping more blood into the blood vessels. So to check the correct blood pressure, the patient or any person should be sitting very comfortably. It is always ideal to apply the cuff on the bare arm and above the elbow level. And the arm or the cuff should be applied at the level of the heart. There should be appropriate sized cuff as well, because there are different sizes of the cuffs depending upon the size of the arm. So a smaller cuff on a bigger arm will give a wrong reading, or a bigger cuff on a smaller arm will give wrong reading as well. So these are the very basic things which all medical related professionals, healthcare professionals, they are aware that how to use the appropriate sized cuff and how to make the patient comfortable before taking the blood pressure. Now, when you start taking the blood pressure, you know that once you start increasing the pressure and you take it to a certain level, 150, 180, it's different for different people. Normally, it's taken to 180. Once you start releasing the pressure, you hear a very sharp tapping noise. And towards the end, these noise, whatever the noise was there, it finishes. So all these sounds which we hear while taking the blood pressure are called Korotokov sounds. So these are different kinds of sounds which give us an idea that what is the systolic blood pressure and what is the diastolic blood pressure. So when the sound actually starts coming to your ears, which is a sharp tapping sound, that is the systolic blood pressure. These sounds go into different phases. They become swish, then they become a bit louder, and then they start to muffle up until they disappear. So when the sound disappears, this is called a Korotokov 5, and that is your diastolic. So that's how we take the readings for the blood pressure measurement. I'm sure I am clear till this point. Now, that was a journal talk about the blood pressure. Now, let's come to pregnancy. What happens in pregnancy? Because although we say that pregnancy is a physiological state, but even with this physiological state, a lot of changes happen in the pregnant lady. So the first important thing is the volume or the blood or plasma volume increases. There is peripheral vasodilatation, which leads to fall in systemic vascular resistance, because when the blood vessels are dilated, there is less resistance for the blood flow. Similar things happen in the blood vessels of the lungs. At the same time, because of the increased plasma flow, the cardiac output increases. The cardiac output is actually the measure of stroke volume, the amount of blood which is pumped multiplied by the heart rate. So in pregnant ladies, the cardiac output is almost 40% than the normal, and it reaches to a highest level at 20 to 28 weeks of pregnancy, that is towards the end of second trimester. So these are just the changes which are happening when a woman gets pregnant. So apart from these changes, definitely something is happening to the blood pressure as well, because the blood vessels are relaxed, they are dilated. So what happens is that blood pressure actually starts to decrease, right? And then from the beginning of the pregnancy towards the middle of the second trimester, it keeps going down and down and down. And then it stabilizes. It comes to a stable level, but it is still lower than the normal blood pressure of that woman before she was pregnant. When the woman enters the third trimester or towards the end of the second trimester, then the blood pressure starts to rise again because of the changes which are happening in the blood vessels again, right? Because of the hormones of the pregnancy, then, and because of the blood which has to be pumped to the baby through the placenta, a more steady pressure is required. So that keeps the blood pressure going up, and it reaches to the normal level which the woman had before she got pregnant. After delivery, blood pressure can fall back again, but sometimes in some women, they can actually get hypertensive for the very first time after delivery. So different women, they have, different type of ways where their blood pressure can go up or down. It can be they can be hypertensive, or they can be hypotensive, depending on how their body reacts to the pregnancy hormones. So this was about the normal blood pressure. So what is hypertension? Hypertension is when systolic blood pressure is more than equal to 140 millimeters of mercury, or diastolic is more than equal to 90 millimeters, or both. Both are higher than these levels. This is hypertension, and it becomes severe when the blood pressure reaches to more than equal to 160 millimeters, the systolic one, and diastolic more than or equal to 110 millimeters of mercury. This is known as severe hypertension. So as I mentioned in the beginning, that there is a wide spectrum of hypertension in pregnancy. That's why we call it as hypertensive disorders. It's just not a single entity. So hypertension in pregnancy can be pre-existing, like some women might have high blood pressure before she got pregnant, and then there is something which she gets when she is pregnant. So while she is pregnant, the type of blood pressure which she gets, we call it gestational hypertension or pregnancy-induced hypertension, which can progress to preeclampsia, and the very severe form is eclampsia. So I'm going to talk about all these in a little bit detail, and I know I have promised you that I won't bore you. So the incidence of hypertensive disorders. This is very important, because why are we talking about hypertension in pregnant ladies? The reason is that 10 to 15% of all pregnancies, they have some sort of hypertensive disorder. So this is a very significant number. Like out of every 100 women, or 10 or 15 women will develop hypertension at any time during their pregnancy. 10% of the primiparas, that means those who are getting pregnant for the very first time, they will develop preeclampsia. 1% might actually develop severe preeclampsia. And out of those who do have mild or severe preeclampsia, 1 to 2% of them can actually go and develop eclampsia, which is the most severe form of hypertensive disorders. So talking about the incidence, it is just blood pressure. So why do we worry about it? What is so significant that we have to talk about these disorders in pregnancy? The reason being that these hypertensive disorders are actually the leading cause of maternal morbidity and mortality, which means still at this time and in this modern world, still there are women who are dying because of hypertension, which happens during pregnancy. 12 to 15% of all admissions which happen for pregnant ladies, they are due to increased blood pressure. Pregnant ladies, when they are admitted or when their blood pressure is difficult to manage, then we have to deliver them. And there will be iatrogenic prematurity for the baby, like the doctors deliver the babies prematurely. And the statistics from the UK is that death rate because of eclampsia is about 1%, and which is very significant. Now, let's talk about pre-existing hypertension. That means a woman who is already hypertensive, she becomes pregnant. So pre-existing hypertension can be actually of two types. The one in which we don't know what is the reason. She's just hypertensive, right? This is called as primary or idiopathic hypertension. And then there might be a cause which results in hypertension or high blood pressure. So the important causes can be renal, any problems with the kidneys, artery stenosis, or actual parenchymal disease of the kidneys, some endocrine disorders, for example, pheochromocytomas, aldosteronism, cooptation of aorta, and some medicines can actually result in hypertension. For example, oral contraceptive pills, non-steroidal anti-inflammatory, some stimulants, cocaine, steroids. And these days, especially for the young boys, they go to the gym and, they want to develop their six packs. And some of them can actually start taking anabolic steroids, which can ultimately result in hypertension, right? So these are the reasons. These are some of the reasons. There is a very long list, but these are some of the important reasons which can result in hypertension. And this is called as secondary hypertension. This secondary hypertension can result, or chronic hypertension can cause multiple comorbidities to the mother. So she can actually develop preeclampsia. I will go into further details what is preeclampsia and why am I emphasizing a lot on this terminology. They can have placental abruption, where the placenta can actually separate before the birth of the baby. Babies can be growth restricted. Mothers can get bleeds into the brain. They can have heart failures. Their kidneys can fail. And there might be a lot of prolonged hospitalizations, multiple admissions, separation from the family, separation from other children. This can lead to mental health issues, depression. So these are the things, and these are the comorbidities which do happen. And whereas the baby is concerned, so when we talk about pregnancy, always remember that we talk about the mom and we talk about the unborn baby, which is the fetus. So once we are concerned about the mother, we are actually concerned about the baby as well. So what's happening to the baby? Babies can actually be very low birth weight. To save the mother, sometimes we have to deliver them and bring the babies prematurely when they need to be admitted in the NICUs. And severely preterm or premature babies, they have a high mortality rate. So, and especially if there is placental abruption, even the term babies can die in utero or die before they are born. So how do we manage it? If a woman is hypertensive, she definitely knows about her medical condition and she is planning to get pregnant, then the most important thing is to provide her with preconception care. This is a very important area in obstetrics, which can actually be provided by a multidisciplinary team. Now, what is a multidisciplinary team? It is a group of doctors which see the patient together and they make a plan for her future care. So preconception care will definitely involve an obstetrician because this is hypertension. So any person who is part of obstetric medicine team, there are special physicians who deal the medical disorders in pregnant ladies. This might have dietitian. There will be a specialized nurse for that. So this is a group of medical healthcare professionals which provide preconception care. The main idea of preconception care is basically the counseling and education of the patient. You talk about the problems which she can have if her blood pressure is not controlled before she gets pregnant. So you talk to her about all the risk factors I have mentioned, which can happen to the mother, which can happen with the baby. So you educate her about her disease. By this education, you are actually trying to make this lady more compliant. So she will be more attentive to whatever advice or suggestion you give to her, right? So this way, she will be able to have full awareness and full understanding of her condition and how is she herself going to make an impact on her pregnancy, because it's both ways. The medical disorder can actually worsen because of the pregnancy, or medical disorder or hypertension can actually affect her pregnancy. So she should be fully aware about her future care planning. So some of the women can be on angiotensin converting enzyme inhibitors and receptor blockers, which have to be discontinued before she gets pregnant because these medicines are teratogenic and it is not safe to continue these medicines in pregnancy. Another important thing is lifestyle changes. These days, majority of us, even the doctors, we have a very sedentary lifestyle because most of us, although physicians, we are working even long hours. We sit in front of the computers, keep seeing patients, and keep documenting. We don't move from our chairs sometimes 4 to 6 hours at a stretch. Stress. Lifestyle these days is very stressful, especially for the younger generation. You know, the social media, to look beautiful, to look good, to be presentable, to post your status so your friends and family and other people can see you. This is stressful. And this is actually the age where everybody has to be careful about their lifestyle. This stress might lead to smoking habits, might take towards drug addiction. So these are the things which the young generation, and especially you guys, you are all very young. You have just started your journey. So try to avoid the stress, and that is the education and that is the information you have to provide to your patients as well. And this is called a lifestyle change. So we provided the preconception counseling, and the lady is now pregnant. So she will now receive the antenatal care. This antenatal care will also be for a high-risk pregnancy care. When she is 12 weeks pregnant, we start low-dose aspirin. Low-dose aspirin is basically started because it helps in maintaining the blood flow through the placenta to the baby. And this avoids the risk of having a growth restricted babies as well. So this is recommended to start a low dose aspirin for the mothers who have hypertension before they get pregnant. Our aim for these patients to have a target blood pressure of 135 to 85 millimeters of mercury. Still, if the blood pressure is not very well controlled, it is advisable to see them every week in antenatal clinics. But if their blood pressure is controlled, we can see them every 2 to 4 weeks. In some parts of the world, there is actually midwife care available where the midwives can take care of the patients so they don't have to come to the hospital every visit. So in 2 weeks, they can be seen by their midwife or GP, and every 4 visits, every 4 weeks, they actually come to see the consultant or an obstetric specialist. At every visit, urine analysis is done and just performed to check if there is any protein in the urine. And I'll come to this point, why do we have to check the proteins? Regular growth scans, usually 3 to 4 weeks interval is adequate to perform fetal growth scans to make sure that baby is not growth restricted. And as I mentioned previously, these hypertensive mothers can have growth restricted babies because of inadequate blood supply through the placenta to the baby. So now it's time to decide when to deliver. Normally, if the blood pressure is very well controlled, there is no need to deliver the mother prematurely. So 37, 38 weeks is a good time when the baby is mature enough, will not need any additional support after the baby is born, and it is safe for the mother as well to be delivered at this time. Aim is always vaginal delivery unless there is a contraindication. And by contraindication, I mean that there is no way that this woman can deliver vaginally. For example, if the placenta is low lying or she has had multiple previous cesarean sections. So, of course, she will directly go for an elective cesarean section. When she is in labor, there will be continuous, not continuous, a regular blood pressure monitoring. Normally, we measure the blood pressure every hour throughout the labor. Pain relief is very, very important to provide to these women when they are in labor, because pain can actually increase the blood pressure. So a good idea is to offer them epidural, and an early epidural can help them to stay pain-free, and it will help with the stabilization of blood pressure as well. And we have to keep an eye on worsening blood pressure, or if they develop any headaches or vomiting or any associated symptoms of high blood pressure. Once they deliver, then definitely they are monitored in the postnatal wards, and different units have actually different policies for hypertensive mothers. Some actually, for the first 24 hours, they measure the blood pressure every 4 hours, and then daily for the first 2 days. If everything is fine, actually mom can be discharged on the second postnatal day, but then they get either a midwife to visit them, or they come to the hospital in 3 to 5 days for rechecking the blood pressure. Aim here in postnatal period is to keep the blood pressure under 140/90 millimeters of mercury. Sorry, I did not mention about the medicines which they can take, but I will talk about the medicines later when I talk about preeclampsia. But one of the medicines which is used for controlling hypertension is methyl dopa. It is not a very good medicine as far as an antihypertensive is concerned, but it is one of the medicines which can be safely given in pregnancy. So if a woman is taking methyl dopa in pregnancy, it should be stopped within 2 days after birth, because it can actually cause depression, and it can worsen the pre-existing mental health issues if a woman continues to take it in postnatal period. And then these women, actually, they already have their dedicated physicians who are taking care of their hypertension. So in 6 to 8 weeks' time, they go back to their primary physician. Now, pregnancy-induced hypertension. So what is pregnancy-induced hypertension is a woman with a normal blood pressure actually conceives, and then after pregnancy, she becomes hypertensive, right? Mostly this comes in the second half of the pregnancy, and then it resolves after delivery. Happens in pregnancy, normalizes, comes back in the next pregnancy, normalizes, comes back again. So for some women, it can always, it keeps coming back. But sometimes what happens is after 1 or 2 pregnancies, it does not normalize. It just stays at a borderline high level. And then actually these women become hypertensive, and they go back into the category of chronic hypertension or primary hypertension, to be fair. So when a woman develops pregnancy-induced hypertension, now our job as obstetricians is to check that if this is simple hypertension or this is preeclampsia. Because simple hypertension, although it can cause morbidities in the mother, but it is not as severe or as critical as is preeclampsia. So for preeclampsia, we have to be very watchful. We have to make sure that women is not developing this entity. So what is the diagnosis of preeclampsia? Blood pressure and accompanied by proteinuria. One of the previous slides I mentioned about that in antenatal period, we check proteins in the urine at every visit. Why? Because if there is protein in the urea with high blood pressure, that is preeclampsia. All right. There can be other maternal organ dysfunctions in this condition. There might be renal involvement. There might be liver involvement. Some neurological complications will be there. Some hematological abnormalities like low platelet count can come. And then there might be uteroplacental dysfunction, which can result in fetal growth restriction. And sometimes, if placental abruption happens, the babies can be stillborn as well. I will go back, I will actually explain these in a little bit more detail for you to have a better understanding about preeclampsia. So, does everyone get preeclampsia in pregnancy? The answer is no. There are some risk factors which predispose a woman to develop preeclampsia. There are 4 broad categories, can be journal, genetic, obstetric, and medical risk factors. So talk journal risk factors. Women who are more than 40 years of age, or they are on the obese side of the spectrum with a BMI of more than 30, they are at higher risk. Genetics actually plays a vital role in developing blood pressure. So you all know that hypertensive disorders, diabetes, these kind of things actually run in the families. Similarly, the hypertensive disorders in pregnancy also run in the families. So if a woman had a mother who had preeclampsia, this lady will have a 20 to 25% risk of developing preeclampsia herself. And if her sister had preeclampsia, the risk goes up to 35 to 40%, which is very significant. It's actually a very high risk of developing preeclampsia. Obstetric risk factors, if a woman is getting pregnant for the very first time, she's at high risk. if she is carrying multiple babies like twins, triplets, quadruplets, the number of babies higher, the higher the chances of developing blood pressure. If she had preeclampsia in one of the previous pregnancies, if the baby has hydrops fetalis, that means this is a condition in which the babies start developing anemia and they get big and edematous. And then the hydatiform mole, these are the abnormal forms of pregnancies where the placenta actually develops into grape-like bunch, and does not develop into a normal pregnancy. And this is kind of a miscarriage where the women needs cleaning the womb. So this is one of the risk factors where the women can actually develop or can actually present for the very first time with high blood pressure and found to be having a molar pregnancy. Medical risk factors, definitely pre-existing hypertension, if she has a renal disease, diabetes with or without any renal involvement is a risk factor, antiphospholipid syndrome, connective tissue diseases, sickle cell disease, especially with the renal involvement. This is just a small list of medical disorders because these are the significant ones, but the list is actually never ending. It's a long list. So now, coming to the pathogenesis, why preeclampsia happens? There are basically two steps, and I will try my best to keep it as simple as possible because this pathogenesis of developing preeclampsia is very complicated. And to be honest, if you ask me, I also get confused sometimes. Yeah. So I have tried my best to keep it very simple for all of you, even for this high school students, that they can get an idea and they will know, they will be confident to talk about preeclampsia later on. So there are two stages. First stage is where the placental circulation actually becomes abnormal. And as a response to this abnormal placentation, the mother shows some backlash to that. There is a maternal response. So what happens when the placenta is developing? So ideally, in a normal pregnancy, you all know that there are three main layers of the blood vessels. The middle cycle is of the smooth muscles, and the innermost lining is the endothelial cells. So in normal pregnancy, the muscular layer and the endothelial layer, actually, they get disrupted, if I can show you. So this is the muscular layer, and this is the endothelial lining of the blood vessels, of the arteries. In normal pregnancy, what happens is that these both layers are actually disrupted, and the trophoblastic cells. The trophoblastic cells are the cells which come from the placenta. So they start to invade these blood vessels. Now you can see that the lumen has actually increased, and there is no smooth muscle which can contract these arteries. So there is loss of vasocontractility. They keep dilated, they stay dilated all the time, and as a result of this dilatation, there is increased blood flow into the placenta, into the spaces which we call as intervillous spaces. So this is what happens in normal pregnancy. But sometimes this does not happen, and the muscle layer as well as the endothelial layer does not disrupt. The body or the arteries, they do not allow this to happen. So the trophoblastic cells actually do not get any space to invade that area. So the vasocontractility of these blood vessels is retained. They stay pulsatile, they control the blood flow. That is the reason insufficient blood flow goes towards the placenta, and this results in uteroplacental ischemia. Ischemia means lack of blood flow. So inadequate blood is actually going from the mother to the baby because of these narrow intervillous spaces. There is a very less area of the placenta, which is actually taking the blood from the mother to the baby, and there is lack of proper maternal and fetal exchange. So this is abnormal placentation. It should not be this way, but it happens. So what happens next is then when the trophoblastic cells, they are trying to invade the endothelial cells, which they can't. So inflammatory response starts to come into play from the mother side, and that is actually quite exacerbated. You know that whenever there is inflammation in the body, there are so many inflammatory markers which come into play. There are lots of cytokines, tumor necrosis factors, endothelial growth factors. There is a very huge number of these inflammatory markers which come into play. You don't have to memorize the names of these things. Only thing which you need to remember is that these inflammatory markers, they come into a very high numbers, and then they cause endothelial dysfunction and microvascular damage, not only around the placenta, but all around the organs, different organs of the mother, because these cytokines, they are circulating with the blood. So wherever they go in the body, they cause damage. So what do they do? Because of this endothelial dysfunction, when these inflammatory markers go to the kidneys, they start damaging the kidneys. The parenchyma, which is the renal parenchyma or the main bulk of the kidney, starts getting disturbed. And this results in protein excretion into the urine. So that is a significant sign of preeclampsia, that kidney has been affected because of the inflammatory markers, which actually have come because of the pregnancy, right? Same thing happens with the liver. So liver enzymes start getting elevated. Liver is a huge organ. So, and liver has the tendency to continue working even after a lot of stress. But what happens is that liver can get congested. It keeps on taking the blood to normalize the functions, but this congestion can actually sometimes can result in the rupture of the liver capsule. The liver enzymes, especially the transaminases, ASTs, ALTs, they can go abnormally high. It can affect the coagulation, because all of us know that coagulation factors are formed in the liver. So if liver is not working properly, there might be disturbances in the coagulation. And women with preeclampsia and eclampsia can actually develop DIC, which is, a very huge risk factor for coagulation. Same thing happens with the brain. So there might be edema of the brain, which results in severe headaches. And this edema can actually lead to seizures as well. So when preeclampsia happens, these are the risk factors, and these are the etiological factors which are causing disturbances in different organs of the body. There will be some symptoms. Sometimes they might be absent, but in majority of the cases, the women can present for the very first time with severe headache, flashing lights. There might be visual disturbances, because edema of the brain can affect the nerves, can affect the eyes as well. So they can either they can just have some hazy vision, or there can be flashing lights in front of the eyes. Epigastric pain, because the liver is involved, and as I mentioned, the congested liver can be very tender at times. This can lead to severe nausea, vomiting as well. And there will be edema, there will be fluid collection in the whole body. So the women is actually swollen. You can see preeclamptic women actually have very typical facies. Their nose is swollen. They can have peri-orbital edema. Their face is swollen. Even the family says that she looks odd. She looks very swollen. So that is a very recognizable symptom as well as a sign in cases of preeclampsia. So So signs which we have to see, definitely it's increased blood pressure, protein in the urine, epigastric tenderness. Then a very significant sign in preeclampsia is brisk reflexes and the development of clonus. Placental abruption, a woman can actually land in emergency department with sudden onset of painful vaginal bleeding because the placenta has separated before any signs of labor, before the baby is born. It can be excruciating pain. Sometimes there can be so much bleeding inside the womb that women can collapse, right? So this abruption can happen because of sudden surge in the blood pressure, so that placenta actually cannot handle that pressure in the blood vessels, and it just comes off. It just separates itself from the wall of the uterus, and this results in death of the baby, definitely, because baby is not getting any oxygen at all. And if the bleeding is heavy, very severe, it can cause maternal death sometimes. So investigations, as usual, we have to check if the liver is functioning appropriately, what are the levels of liver enzymes, renal function tests, check for proteinuria, urine protein, creatinine ratio is important, and if it is more than 30 milligrams per millimoles, it is significant that, I'm sorry, that kidneys are affected, might be low platelets, there might be some hemolysis as well. So these are the important investigations. With preeclampsia, what complications can happen? So eclampsia is the first thing, which can be the next step in cases of preeclampsia. There might be HELP syndrome. HELP syndrome is another form of preeclampsia where there is elevated liver enzymes and low platelets. Can be pulmonary edema because there is extra water, there is third space fluid collection in the whole body. That is the reason women appears swollen, there is pedal edema, there is facial edema. So definitely there is pulmonary edema, which can be life-threatening as well. There can be cerebral hemorrhage, renal failure. These are all complications of preeclampsias. And if this keeps on going, it can become from mild preeclampsia to severe preeclampsia. And as obstetricians, it is sometimes very challenging to decide that if this woman needs delivery or not, because definitely these women have to be admitted in the hospital, but to decide about the timing of delivery is a challenging aspect because we have to see whether it is safe for the baby to come out if preeclampsia has developed at a very early gestation. And at the same time, we have to keep in mind that if this preeclampsia worsens, and for some patients, this can actually happen within a matter of hours. They deteriorate very quickly, even sometimes within minutes. It becomes very difficult to control the blood pressure. So we have to keep an eye on the worsening symptoms. Talking about eclampsia, so a pre-eclamptic woman can develop tonic-clonic seizures, and this is known as eclampsia. This happens because the cerebral edema or the edema in the brain has reached to such an extent that mental deterioration starts, and the brain actually does not know what to do. So it starts, getting activated at different areas in the brain and starts having different types of impulses. So this results in tonic-clonic seizure. In pregnancy, 45% of the times this can happen in pregnancy, during labor, and in postpartum period. So there is no specific time period when eclampsia can happen. It can happen anytime in pregnancy and even in postnatal period. And that postnatal period might be from delivery up to 6 weeks. teenagers are 3 times more likely to have eclampsia. And as I mentioned, that the women, the primigravidas, who are the women conceiving for the very first time, are already at high risk. So if a primigravida is teenager, her risk actually increases. How do we manage? You all know that management is not just treating, management is actually diagnosing a disorder properly, then how to monitor it, and then definitely comes the treatment part. So diagnosis, I have already explained, I have already talked about it, how to diagnose, what are the symptoms, what are the signs, and what are the laboratory investigations which will confirm the diagnosis of preeclampsia. But most of the times it is the clinical diagnosis. So once a woman is diagnosed as preeclamptic, safest option is to keep her admitted in the hospital. And again, different hospitals have different policies, how long they want to keep the women in hospital, or she has to stay till she delivers. It depends. But a safe approach is to keep the women in hospital and keep an eye on her blood pressure and watch for the symptoms for severity of the condition. So once she is admitted, she will have regular blood pressure monitoring, regular urine analysis, regular lab investigations, which we did when we were diagnosing the preeclampsia. And again, the fetal monitoring. So mom is one entity and the baby is the second one, and we have to make sure that the baby is not ignored. We are just not treating the mother here. We have to be watchful for the baby as well. So those women who develop preeclampsia at very early gestation, then there is a risk that their babies will start having growth restriction from very early on. So uterine artery Dopplers can be performed at 20 to 24 weeks of gestation. And if these Dopplers are abnormal, actually, if they have notch, there is a special way of measuring the Dopplers on ultrasounds. And the persons who are doing these uterine artery Dopplers, they tell us that this is not normal. So these women are actually at risk of having a growth restricted baby. These to find out if these babies are really growth restricted, we perform regular ultrasounds, and that regular ultrasound means to perform every 4 weeks and check for the growth of the baby. There are customized growth charts for the babies. Again, different units have different types of charts. The estimated weight of the baby is plotted on those charts, and then we monitor the baby is actually growing according to its growth potential and is not coming down. If any acute event happens, mother goes in labor, she starts complaining of abdominal pain, or she does not feel the baby moving. In case of these acute events, we monitor the heart rate of the baby, which is known as CTG. So what is the medical treatment? There are two major entities while managing preeclampsia. One is antihypertensive, and the second one is anticonvulsant. So the safest antihypertensives which we can use in pregnancy are mainly 3 medicines which we can easily use. Yes, there are other options when these are not helpful, these are not able to control the blood pressure. That means the blood pressure is so resistant and is so severe that we need to definitely give them some other sort of medication. The first one, which is most commonly used all around the world, is labetalol. It is a combined alpha-beta adrenergic blocker, but cannot be given to asthmatic patients. Then is methyl-dopa. You remember I mentioned that those females who are taking methyl-dopa, they have to discontinue this medicine within 2 days of delivery because it causes depression. And then nifedipine, which is a calcium antagonist. These are 3 most commonly used medications, antihypertensives, given in pregnant ladies. As I said, anticonvulsant. So why do we need an anticonvulsant? First of all, in preeclampsia, especially those preeclamptic women who start to develop headache, vomiting, epigastric pain, they are at risk of developing eclampsia. That means there is a possibility that they might throw seizures because of the brain edema, and they might become eclamptic. So whenever there are symptoms of worsening preeclampsia, or when they actually have developed a seizure, then we give them anticonvulsants. And the drug of choice for seizure prophylaxis and treatment is magnesium sulfate. What do magnesium sulfate do? It actually blocks the excitatory NMDA receptors, which are N-methyl D-aspartate receptors in the brain, and it causes cerebral vasodilatation. So the blood flow to the brain is maintained, and at the same time, it blocks the calcium channels and tries to reduce the brain edema. So that's how it helps in preventing seizures in pregnant women. But magnesium sulfate has some side effects where it can affect the kidneys and it can reduce the urine output. It can also affect on the muscles, and actually it can affect on the respiratory muscles. So when a woman is on magnesium sulfate, she has to be nursed in high dependency unit, which is the HDU care, because they need continuous monitoring of the blood pressure. They need monitoring of the respiratory rate, as it is very important because their respiratory muscles can be affected if the magnesium sulfate reaches to a toxic level in the body. Their urine output has to be measured. So these women are actually catheterized to measure the urine output, or if they do not have a catheter, at least every time they void, they are given a jar and through which the output is measured. At the same time, fluid is restricted for these women because they already have a lot of third space fluid collection. So intravenous fluid is given to them at a very restricted rate. And the maximum which they can receive is actually 80 ml per hour, which is a very small amount actually of fluids. But that's how we have to control their intake and output. Now, what is the treatment of preeclampsia and eclampsia? It's only delivery. Without delivering the mom, you cannot actually cure the preeclampsia and eclampsia. So ultimately, we have to decide when to deliver this woman. So if she is in early gestation, like let's say 28 weeks, 30 weeks, 32 weeks, which is far, away from 40 weeks, which is actually the time of complete pregnancy. It is sometimes very challenging decision for the obstetricians because they have to see what is the safest approach. If we deliver the baby, how much support this baby is going to need, admission to the neonatal unit. Maybe the baby will need respiratory support, some medicines for the lungs, maybe baby has to be intubated. But at the same time, we have to think about the mother, that if we continue the pregnancy, is it going to adversely affect the mom? And she might actually end up having some irreversible organ damage. So this is the decision which is made by the obstetricians. Sometimes we involve the obstetric medicine team, definitely the neonatologists. We are who are the baby doctors. They have to be on board as well, because the mother will need counseling to know that if a preterm or a premature baby comes into the world, how much support this baby will need, and how long this baby is going to be admitted. So that's how this delivery has to be planned. Sometimes we have to deliver the mothers as an emergency, because if she develops abruption, then there is no point in waiting. If her blood pressure keeps on worsening with worsening signs and symptoms, there is no point in waiting and prolonging the pregnancy. So then these are the indications where we just have to go ahead and deliver the baby. irrespective of the gestation. Sometimes in these conditions, we don't even bother if the baby has, has the potential to survive if the baby is born, because definitely mother's life gets the priority. So this is the decision which has to be made by the senior obstetricians. Once the mother is delivered, we have to continue the magnesium sulfate for at least 24 hours after the delivery, because there is still 35 to 36% risk of having eclampsia in the postnatal period as well. Target blood pressure is 130/80 millimeters of mercury. And as long as the woman is in HDU, there is actually hourly measurement of the blood pressures. When she is stepped down to the normal postnatal care, they measure it every 4 hours for at least 24 hours and daily. Then women can be discharged on third or fourth day, depending upon her blood pressure control, depending upon her signs and symptoms, and depending upon her recovery. She can be discharged, but yes, she will be given follow-up appointments. There will be medications which she will be taking on, and then there will be actually there are multiple visits where she comes for the blood pressure monitoring and to decide like how long she can continue on these medications. So that's it from my side. I hope you guys have understood even a little bit is fine for me at this stage. I have tried to keep it very, very simple. And I hope that you guys have at least gotten some sort of understanding about the blood pressure. I'm happy to take any questions.
Hello, Dr. Ahmad. I want to thank you for your mentorship and teaching, and we will begin our Q&A session now. The first question is, what are the most challenging aspects of being an OBGYN?
All right. So the most challenging thing I would say is working hours and to maintain a work-life balance. This is the question which majority of the medical students and internees actually ask us, that how do you do that? So it depends. It depends what are your priorities and how much passion you have to pursue obstetrics and gynecology, because this specialty is not for the weak heart. You have to be very, very passionate to pursue your career in obstetrics and gynecology. And yes, there will be times when you have to sacrifice family life. There will be times when you have to, compromise your sleep as well. So that's how it is. But eventually, when you reach to a certain level, this physical stress eventually gets lesser, but the mental stress becomes more when you reach to a stage when you are the ones who have to decide. You are the decision maker for complicated cases, for challenging cases. Then sometimes you're just at home, but the juniors are calling you and asking your opinions, and you have to decide and all that. So it's all about the priorities. It's how much are you passionate about pursuing the career.
For sure. And with that, can you walk us through like a day in your life and what you do on a day-to-day basis as a OBGYN?
Right. So I actually work on shift basis. Like I work in a government hospital. So we have to, specific hours per week, which we have to do. So that includes 12-hour shifts. Most of the time, there are 3 12-hour shifts in a week and 1 clinic, which is 9 hours. So these 3 12-hour shifts can include either 1 night or 2 nights in a week. So during when I have to go for the night, I am free all day. So I can sleep, I can do whatever I want to do, I can pursue any hobbies if I have anything to do, talk to my parents back home, spend time with my children. My children are now actually away, they are both in universities. So I can just have me time. And then after the night, come back in the morning, and then that day again is my own day, which I spend sleeping and act like a zombie most of the times. But still, it's my day. So,
For sure.
yeah, I mean, you get used to it eventually.
Yes, yes. And for our last question, how do you manage your work-life balance? Do you have specific hobbies you do to kind of decompress, or what does that look like for you?
Yeah, for me, yes, I try my best to maintain my work-life balance because I don't bring home any documentation, any hospital work at all. And when I'm at home, I have actually, my house is far, far away from the hospital. I have intentionally taken, an area where they cannot call me in case of emergency. I tell them, oh, I live very far away, so it's very difficult for me to come on urgent basis. But yes, so whenever I am at home, I spend time. I I don't know, I should say it or not, but I have interest in politics. So I just follow that. I enjoy actually listening to different podcasts, different discussions about current affairs. So that's my stress relief. Actually, it's not. It gets me hypertensive listening to the current situations, but this is what I like.
For sure. It's good to have some hobbies to take your mind away from your work and just everything happening on the other side. For sure. Nice hearing about those. So those are all the questions we had for today. We would like everyone to give a warm thank you to Dr. Ahmad in the chat box for her informative session. So thank you so much.
Thank you so much for having me and giving me this opportunity. But nobody asked anything about hypertension. I think they understood well.
For sure. You're very informative.
Right. Thank you so much.
Of course.
Thank you.
Now we're going to conduct our closing session with our quiz and future session dates. The link to the quiz for this session is now live. You'll need a 70% or higher to pass and receive certification. The link to the quiz is down below. Now on to our next session dates. These dates will be posted through our social media outlets, so be sure to follow us at TeleShadowing. December is OBGYN month. Our next live session will be Sunday, December 10th at 10 a.m. Eastern Standard Time for another OBGYN session. Thank you so much, everyone, for attending today's session. We hope to see you in upcoming sessions as well. This concludes this week's shadowing. Thank you.
Bye.